Good afternoon, ladies and gentlemen, and we are continuing on with our ophthalmology clerkship video sessions. We are starting a brand new theme, which is ocular surface and lid anomalies. And the first topic that we'll do includes a couple of conditions, two that are classified under the heading of ocular surface anomalies, which is conjunctival degenerations and corneal deposition. The other two conditions under the second heading of lid anomalies is lid margin anomalies and lid swellings. So this theme, ocular surface and lid anomalies, might seem like, I've just decided to put a lot of condition under one theme because they wouldn't fit anywhere. But no, this is really a proper form of patient presentation. And remember, all of our themes revolve around some form of patient presentation. And here, the patient is presenting with some form of ocular surface anomaly or a lid anomaly. And today we'll be talking about several conditions, and those are as shown on your screen. Under the heading of ocular surface anomalies, we'll be doing conjunctival degenerations. Within conjunctival degeneration, we'll do two conditions, pingicular and pterygium. Under corneal deposition, we'll do just one, Arcos Juveniles, or well, actually it's two, it's Arcos Juveniles and Arcos Juveniles, but I've just written Arcos Juveniles because Arcos Juveniles is very similar, it's just the age that's different. Under the heading of lid anomalies, we'll do lid margin anomalies, under which we'll do anterior and posterior blepharitis. Then we'll do lid swellings, under which we'll do chalazion and hordelum, which are benign lid swellings, and basal and squamous cell carcinoma, which are malignant lid swellings. Now, after seeing this, you might feel like, I'm going to be here all day. Well, not really. Once we start off, you'll realize that these conditions are not that difficult. In fact, they're probably one of the simplest things that you can, pick up on a torch examination. So it's not that difficult at all. And in fact, they're so common, most of these conditions, with the exception of the malignant tumors, they're so common that once you see patients in a clinic, you'll see them very frequently. So they're not that difficult to sort of, understand or pick up. And believe me, it's more like a fish swimming than, a person sitting in front of a computer taking multiple mugs of or cups of coffee or tea or a beverage or whatever type of beverage that you would prefer, figuring out this is never going to end. So that's not going to be it. It's rather simple. Before we go on and talk about those conditions that I just mentioned, let's just review the gross structure of ocular surface and adnexa that's relevant to our discussion today. We'll start off by looking at the conjunctiva, and the conjunctiva is a very vascular mucous membrane. It has three divisions. A part of the conjunctiva covers the eyeball, which is called the bulbar conjunctiva. It starts off at the limbus and continues on and covers the anterior part of the eyeball that can be seen when you look at a patient. And it is shown by this yellow color on this diagram, and it is pointed out here in this sort of blue arrow on the picture. The second division is called the conjunctival fornix, which is a little fold of conjunctiva that is sort of pocketed in this little space between the eyeball and the orbit, and it is shown in red in this diagram, and in this picture it is shown by this red arrow right here. The third division is the palpable conjunctiva, and the palpable conjunctiva is the part of conjunctiva that lines the posterior surface of the eyelid, and it's shown in green in this diagram as well as in this picture. And all of these three parts are continuous with one another. So the palpable conjunctiva continues on into the fornix continues on into the bulbar conjunctiva. The bulbar conjunctiva begins at the limbus. The limbus is a transition zone between the cornea and the sclera. The conjunctiva does not cover the cornea. Please remember that. So bulbar conjunctiva, conjunctival fornix, and palpable conjunctiva, three divisions of the conjunctiva. Let's talk about palpable fissure and Kantha of the eye. We'll start off by marking the limbus, and the limbus, as I just said, is the transition zone between the cornea, which is transparent right here. It says so cornea here, and the sclera, which is white, and the conjunctiva covers the sclera. And the part of the conjunctiva that covers the sclera is the bulbar conjunctiva. And obviously, a little bit of the limbus is covered by the upper lid, as you can see here. and it's about approximately 2 millimeters of the superior limbus and the cornea are covered by the upper lid. The palpable fissure is shown in this red dotted line, is the elliptical shape opening between the upper and the lower lid, and the part of the bulbar conjunctiva that's visible through it is called the interpalpable bulbar conjunctiva. You can just call it the bulbar conjunctiva as well if interpalpable bulbar conjunctiva is too much of a mouthful. Let's talk about the canthi, the medial and lateral canthi, the medial and lateral corners of the eye. The medial canthus is rounder right here, shown by the black line and black arrow, and the lateral canthus is more triangular and shown by the white line and white arrow. Kantha are basically the areas where the upper and lower eyelids meet, and they are the two extremes of the eye, or the adnexa of the eye. The nasal conjunctiva and the temporal conjunctiva are the divisions of the interpalpable bulbar conjunctiva. The nasal conjunctiva is the medial part of the interpalpable bulbar conjunctiva, shown in green outline. The temporal conjunctiva is the lateral part of the interpalpable bulbar conjunctiva, shown in yellow outline here. So we'll start off by talking about ocular surface anomalies first, then we'll talk about lid swellings, and as was shown to you before, we'll start off by talking about conjunctival degenerations, and we'll discuss two, peduncula and pterygium. Both peduncula and pterygium are degenerative changes seen secondary to deterioration of the bulbar conjunctiva. They are almost exclusively seen with environmental exposure, specifically exposure to ultraviolet light and dry eyes. We'll start off by talking about a peduncula first, and a peduncula is defined as a bilateral elevated yellow-white thickening of the bulbar conjunctiva. It is most commonly seen on the nasal conjunctiva, and that's because the side of the nose, the dorsum of the nose, acts like a mirror and reflects light onto the nasal conjunctiva. And since these conditions, both pterygium and peduncula, are associated with exposure to outdoors, and as I said before, to UV light, it's that light being reflected off onto the nasal conjunctiva that causes this type of degeneration. It is, although mostly bilateral, it can also be unilateral and can also be seen on the temporal conjunctiva. The etiology is UV exposure leading to elastotic degeneration of the bulbar conjunctival collagen fibers. It is associated with dry eyes, dry climate, and outdoor lifestyle and outdoor professions. All of these things are associated with exposure, and exposure causes this degenerative change. It can also at times become inflamed, and then it is called a pedunculitis. It is usually seen between 20 and 50 years. It is seen more in males as compared to females. That skew could be because of the etiology, which basically is in people who have an outdoor lifestyle. And as in most part of the world, the outdoor lifestyle is something associated with males. Males have it more. And although this would obviously vary by country, and in countries where the males and females have equal amount of exposure, this epidemiological statistic would be different, but generally males get it more than females do. The presentation is a slow-growing conjunctival yellow-colored spot, and it does nothing. Most of the people are just intrigued by it, and they think, oh, maybe this is a cancer or a tumor growing, and they go to a doctor thinking something is growing in my eye. It's not really causing any pain or visual symptoms. I just am curious as to what it is. If it sort of becomes a little large or it becomes inflamed, it can cause irritation and watering as well, because it is associated with dry eyes. If a patient presents with pedunculitis, rather than just being a yellow colored spot, it will be a red colored spot. I'll show you some pictures next. So this is a peduncula. As you can see, it's a yellow raised thickening of the conjunctiva. It really does nothing. This is another peduncula. This is another peduncula. This is actually very zoomed in, so it is you have to look carefully at the way the light is sort of reflecting off or curving off the lesion. And this is pedunculitis, and as you can see, this time it's sort of red, and not only is the peduncula red, the surrounding tissue or the surrounding conjunctiva is a little congested as well. So what do we do? The first thing is simply to observe. As this lesion does nothing, you just tell the patient, look, it's not a dangerous condition. We can just see and observe it while you do some things to protect yourself from exposure. Wear a cap, wear a hat, wear glasses, and use lubricants. So telling the patient what causes this and allowing some lifestyle modifications is the first thing that people do, or mostly. In fact, this is maybe 95% treatment of pingicula, that is observation, in 95% of the people or the patients who come to you with a pingicula. If it is cosmetically undesirable to them, it can be simply excised with laser or with surgery. And if it's a pingiculitis, lubricants together with a brief course of topical non-steroidal anti-inflammatory drugs, flubuprofen sodium 0.03% 4 times a day, or fluoromethanol eye drops 4 times a day till resolution if non-steroids are ineffective. Remember, fluoromethanol is a steroid. You have to limit its use to something that's safe. Pingicula is a condition that can easily be managed or is managed by family physicians or general practitioners. So you should be able to manage it once you sort of qualify med school. And the important thing here is simply to remember, if you are giving a steroid, make sure you tell the patient that this is a steroid, it has its side effects, so let's limit its use. Most of the time, you just tell them to observe, you encourage them to observe it. If it's inflamed, obviously you have to give lubricants together with non-steroidals. And if you give them for a little bit of time, you have to convince the patient, yes, this would work. Most of the time it works. Very infrequently do you have to resort to steroids in order to manage a pingiculitis. The second conjunctival degeneration that we do is pterygium, and pterygium is from Greek pterygos, wing-like, triangular, and it is called a pterygium because the lesion has a triangular appearance. And a pterygium is defined as a conjunctival fibrovascular growth that extends to the cornea. It is classically divided into 3 parts: a head which grows onto the cornea, a neck which is the part that joins the head to the body, and the body is the part of the pterygium that grows on the conjunctiva. The neck usually lies at the limbus. I'll show you some pictures that will make it more clear. As opposed to pingicula, which are usually bilateral, a pterygium is usually a unilateral condition. It's mostly seen on the nasal conjunctiva. And again, the reason that is mostly seen on the nasal conjunctiva is, again, the dorsum of the nose acts like a reflective mirror, bouncing light off onto the nasal conjunctiva. It can be bilateral, which is then called a double pterygium, and it can also be only located on the temporal conjunctiva. The etiology is again very similar to that of a pingicula, which is UV exposure leading to elastotic degeneration of conjunctival collagen. It is again associated with dry eyes, dry climates, and outdoor lifestyle and professions, and it can also become inflamed, which is then called an inflamed pterygium. So the epidemiology here is males get it more than females, but probably because of the same reasons as was discussed when we were talking about pingicula, and develops relatively in the same age group between 20 and 50 years. And the presentation is obviously different because this lesion is larger. However, a small pterygium, a pterygium that's just starting to form, may go unnoticed, and it's usually a friend or a family member or a colleague that tells the person, hey, there's something in your eye. On examination, it appears as a unilateral, triangular, fleshy, slow-growing mass that extends from the conjunctiva onto the cornea. It does grow. It does not sort of remain static. So its size would increase with time. How much and how fast the size would increase usually depends upon what precautions the patient is able to take once it's diagnosed. It can grow large enough to cover the visual axis, that is, it won't allow light to go in the cornea, which can cause visual symptoms. And again, as I said, it's usually on the nasal conjunctiva, but can be bilateral and on the temporal conjunctiva as well. It does cause irritation and watering simply because it is a large mass, so it does cause irritation, and it is associated with dry eye, so would lead to watering because of that as well. It can also lead to reduction in visual acuity for the reason that I just mentioned, that is covering the visual axis, and also because it can cause astigmatism. It is a fibrovascular growth, and it can actually pull the cornea in one meridian and cause astigmatism. I'm sure you remember astigmatism. If you don't, you can go back to the discussion of refractive errors, although you should know what it is. It does appear sort of ugly and undesirable, and that is one of the major reasons for doing something about it, removing it from the eye. An inflamed pterygium would present just like a normal pterygium, with the difference that the eye is going to be much more red and congested, and would again have watering and irritation with it. So this is a pterygium. The green bit is the head of the pterygium. The dotted line is the neck, which lies at the limbus, and the black arrow is showing the body of the pterygium. This is very close to visual axis, but is not covering the pupil, so it may not affect the vision, at least not because of its size. It may affect the vision because of its pull if it causes astigmatism. And to check whether it's causing astigmatism or not, we do keratometry, i.e. measure the corneal curvatures. If you've forgotten what keratometry was, you can go back to the discussion on refractive errors again, because we talk about corneal curvatures there. And this is the entire pterygium, the outline of the entire pterygium in a black solid line. Again, another pterygium. Green is the head, the dotted line is the neck, and the black is the body. This is a double pterygium shown by white arrows, and as you can see, this one is covering the visual axis, so the vision is definitely going to be affected. This picture shows the evolution of a pterygium, or the growth of a pterygium over time, starting from something that's just at the limbus right here, this is the pterygium, to something that's now encroaching on the cornea, may affect vision because of astigmatism, and C, something that would cause reduced vision because it's covering the pupil, the visual axis, and also may reduce visual acuity because of induced astigmatism. So there is a condition called pseudopterygium, and a pterygium needs to be differentiated from a pseudopterygium. So pterygium, as we just described, is a fibrovascular growth of the conjunctiva on the cornea and adheres to the conjunctiva and cornea throughout its length. You can't pass anything underneath it. A pseudopterygium occurs when a conjunctiva adheres to the cornea because of maybe trauma or inflammation, and it can be separated from the underlying tissue, and it can be lifted off the conjunctiva, so you can pass something underneath it. At times, just by looking at the two, it's very difficult to tell apart. So what you do is you take a glass rod or a probe and you try and pass it underneath the lesion. You can't pass one underneath a pterygium because a pterygium is a fibrovascular degeneration of the conjunctiva. It's not separate from it. But a pseudopterygium is a conjunctiva that's stuck onto the cornea, so you can pass something below it. So this is a pterygium. You can't pass anything or a probe below it. It's usually a glass rod. But a pseudopterygium, you can pass through it, as shown by this, black line. And this bit, which is indicated by the blue arrow, is the part of the probe that's passing below the pseudopterygium. So what do we do? If it's just causing a little bit of irritation, you tell the patient, look, this is because of exposure, so we need to modify exposure, self-protection, lifestyle modification. You prescribe lubricants because, it is associated with dry eyes, and sun protection in the form of reducing sun exposure, sunglasses, caps, or hats, something very similar to what we did when we were talking about a peduncula. If it's bothersome irritation or cosmesis, i.e. doesn't look nice or is reducing vision, we need to excise it. And simple excision is thing that was done primarily many years ago, and it's still done at some places, but it is associated with very aggressive recurrence of the disease, because the diseased tissue, the conjunctiva that's causing the pterygium to occur, is not replaced. So a better way, rather than just doing simple excision, is to do any one of these things to reduce recurrence. A is doing an autograft, and that's one of the simplest things you can do. It's the patient's own tissue being transplanted from one place to another. I'll show you a video of how that's done. We can also retard tissue growth by using antimetabolites, 5-fluorouracil or mitomycin C, and these work exactly the same as they did when we were talking about trabeculectomy with mitomycin C, when we were talking about angle closure. We can also use pro-healing agents, and once you have dissected away the pterygium, you can put an amniotic membrane there. And we have talked about amniotic membrane when we were talking about keratitis. And you can combine any of these conditions if you feel that the chance of recurrence with just one of these methods, either autograft or antimetabolite or amniotic membrane, would be high. So you combine any of these methods, maybe all three of these, or maybe any two, or whatever the surgeon prefers. So this is a video of how a pterygium is excised together with an autograft. So the first thing to do is to mark the neck of the pterygium. And then what we'll do, we will inject a little bit of xylocaine, which is an anesthetic, into the body of the pterygium. And now we are going to dissect the head away along the neck. This is Dr. Fogla. He's from India. And now this is the head being removed from the cornea. The head grows on the cornea, so it has to be removed from the cornea. A little bit of dissection to remove it. So now once the head is removed, we are going to cut the body away from the conjunctiva, and the tenon is the layer that's right below the conjunctiva. So both tenon and conjunctiva sort of stuck to one another where the pterygium forms. So when we are cutting the body away, we are also cutting a bit of the tenon together with the conjunctiva. So the body is now gone. Now we are going to mark the area where we are going to take our autograft from. And this is basically the superior conjunctiva. And since this is covered by the upper lid, it's not actually, hasn't gone through the process of degeneration, and you can simply transplant it from here onto where the pterygium previously was. And autografts are the simplest graft. There is pretty much no rejection. It's the body's own tissue, and conjunctiva is so vascular, it just regrows. So taking a graft from the patient is not going to cause any harm to the patient at all. So the size of the graft is approximately equal to the size of the pterygium that was dissected away. The conjunctiva is very elastic, so you can sort of stretch it a little bit as well. It's just fine dissection so as to get the appropriate size graft. Now it's being cut off. It is going to be moved into the position where the pterygium was, or transplanted to where the pterygium is dissected from. It's sort of important to maintain alignment, and this tissue marker helps tell you which edge was which. So once it's properly spread out, we can use 10-0 nylon suture. This is the same suture that was used once in cataract surgery to seal the corneal incision, to close the corneal incision more properly. I'm just going to make it move a little faster, and that's near the end result. So it's stitched on all sides, and this is how an autograft is done for pterygium. Now we are going to move on to the second of our two conjunctival the ocular surface anomalies, which is corneal deposition, and we discuss one condition, Arcos Juveniles, and we'll sneak in another which is called Arcos Juveniles. But it's not a separate condition, so we'll just discuss it together with Arcos Juveniles. Before we go on and talk about Arcos Juveniles and Arcos Juveniles, just quickly review the structure of the cornea. And the cornea was the transparent anterior 1/6 of the globe, and it's not covered by conjunctiva, as I mentioned before. The bulbar conjunctiva is the bit of the conjunctiva that covers the sclera, and the limbus is the great transition zone between the conjunctiva and the cornea. Cornea itself has 5 layers, as can be seen here: a top epithelial layer, Bowman's layer, then stroma. Bowman's layer is just a sort of organized part of the stroma. The basement membrane of the endothelium is called the descent membrane, and then you have your endothelial cells. The deposition that we are going to talk about happens within the stroma of the cornea. So what is this Arcos Juveniles and Arcos Senilis? Well, Arcos Senilis is a bilateral deposition of lipid in the peripheral corneal stroma, leading to a white ring-like opacity in the peripheral cornea. This is considered a normal aging process, Arcos Senilis. It usually starts after the age of 40, and it's usually at 50 that you start seeing this. And this happens because with increasing age, you have increasing permeability of limbal vessels, which is then able to pass low density lipoproteins through to the periphery of the cornea, specifically the stroma of the cornea. It is also called the gerontoxin in Arcos lipoides and Arcos corneae or corneal arcus. Even I had not heard of some of these terms before. And Arcos juvenilis is very similar to Arcos senalis with the exception of age. So it's again a bilateral deposition of lipids in the peripheral corneal stroma, but this is something that's starting at less than 40 years of age. And it's really important to do a complete lipid workup because this can and is associated with dyslipidemia and hypercholesterolemia. So what are the risk factors that are associated with Arcos senalis? Old age. It's usually 70% of individuals who are more than 70 years of age would 70% of individuals who are more than 60 years of age would have this. I was becoming a part of the PTI government there. And essentially all males over the age of 80 would have it. Male gender is usually the one that gets it before. Females usually get it later, 10 years later in terms of age of presentation. Smoking, hypertension, fasting serum triglyceride levels, hyperlipidemia, and familial hypercholesterolemia are all risk factors for Arcos senalis. It is also associated with xanthelasma. I'll show you a picture, and I'm sure you know what a xanthelasma is. It's a sharply demarcated yellowish deposit of cholesterol underneath the skin. So you see xanthelasma together with Arcos senalis pretty frequently. In terms of presentation, well, it's usually a white ring that the patient starts complaining of. They say, I see a ring in my eye, and they usually tend to confuse it with a cataract because it's white in color, and they think that they're getting a cataract. When you see it or you examine it, you see a complete or an incomplete ring in the corneal periphery, which is separate from the limbus. There's a little bit of a clear zone. It usually starts superiorly and inferiorly because those parts are covered by the lids to varying extents. The upper lid covers the superior limbus more than the inferior limbus. And that's because these zones have lesser temperature, and that's somehow thought to be associated with the ring starting to form superiorly and inferiorly first. As far as Arcos juvenilis is concerned, the presentation is going to be similar to Arcos senalis with the exception that the starting age of the lesion is less than 40 years. So this is how it appears. This is early, this is late. More lipid deposition makes the white become whiter. So this is less dense, this is more dense, and you can see that there's a clear zone between the limbus and the Arcos as shown by the blue arrow. The white arrow shows the Arcos. These are xanthelasmas. So what do we do about it? For Arcos senalis, really it's something that you just tell the patient it's not a cataract. You would see it. Just to be sure, get their lipid profile done if there is a family history of dyslipidemia or hypercholesterolemia. If it's a unilateral disease, then you really have to do workup for carotid vascular disease because maybe on one side there is something going on to the carotid vasculature that is causing this to happen, because remember, this is a bilateral condition. This is exclusively bilateral. If you have Arcos juvenilis, it will always require workup because it is indicative of dyslipidemia. So you need to do lipid profile and appropriate referrals to an endocrinologist or an internist to make sure that your patient does not have any underlying condition that is responsible for formation of Arcos at a younger age. Now we are talking about the second half of our discussion, which is lid anomalies, and we'll begin by talking about lid margin anomalies, and we'll discuss two conditions here. Well, again, three. We'll sneak in a third one. Anterior and posterior blepharitis, but there is a third one as well. Before we go on and talk about those blepharitis, let's just look at the lid margin. The lid margin is basically shown in the picture as well as the diagram. And it has a posterior component and an anterior component. The posterior component is basically a continuation of the palpable conjunctiva, and it has the opening of the mebomium gland right here, this part. The interior part of the lid margin is continuation of the skin on the interior surface of the eyelid, and it is associated with the eyelashes or cilia, this part. So this is the posterior lid margin, and it has opening of mebomium glands right here in the diagram and right here in the picture. You need to be very close to it maybe to see it, especially if you're on a cell phone. But there are these yellow spots, and since the color of these mebomium glands is basically sort of yellowish, so you can see the opening as a yellowish dot. You can see them. They're sort of present here And this is what they normally look like, these openings. It's really difficult to see with a naked eye and a torch, so you can use a torch together with a magnifier, or if you have a cell phone which has very good zoom, optical zoom, so you can probably use that. And if you have really stable hands, or you have optical image stabilization, or even if you have electronic image stabilization, that will also work, but optical is better. So anterior lid margin, you have your lashes covered by skin. Posterior lid margin, you have openings of your meibomium glands. Meibomium glands are sort of modified sebaceous gland. They produce the oily part of the tear film, which is called meibomium. And this part of the lid margin is covered by conjunctiva. There's an arbitrary line, which is called the gray line. It's imaginary and arbitrary. It's not there. This is drawn just to show where it would be, which tells you this is where the skin ends and the conjunctiva starts. But honestly, the zone of transition between the two is very diffuse. There is no clear-cut skin ending, conjunctiva starting. It's a very diffuse sort of an arrangement or a transition between a skin and the conjunctiva. So we'll start off by defining blepharitis, talking about its epidemiology and classification. Blepharitis is the most common ocular disencounter, most common clinical encounter in an ophthalmology clinic. It's the most common thing you see in a clinic of an eye doctor. It is defined as a bilateral chronic inflammation of the lid margin, and it's seen in all ages, from young people to really old people. It is basically mostly seen in individuals who are around 50 years of age, and females get it more than males, maybe because of use of makeup. And it is classified into an anterior blepharitis, a posterior blepharitis, and a mixed type. This mixed type is the one that I am sneaking in. So anterior blepharitis is inflammation of the anterior lid margin, anterior to the gray line. Posterior blepharitis is inflammation of the posterior lid margin, posterior to the gray line. And mixed it, both anterior and posterior type present in the patient. And there are basically, we'll start our discussion off with anterior blepharitis, and anterior blepharitis is defined as chronic inflammation of the anterior lid margin of both eyes. So it's a bilateral condition. It is of two types, Staphylococcal type, which is because of bacterial toxins, and it is further enhanced by the action of body's immunity against the bacteria. The other type is called the Seborrheic type. The cause is really not known, but it causes less amount of inflammation as compared to the Staphylococcal type. The Staphylococcal type is obviously caused by the Staphylococcus bacteria, and the two most common staphylococci found are the aureus and epidemiolitis. And it's very interesting how these bacteria actually cause, or are thought to cause, anterior blepharitis, and that is by a mechanism called quorum sensing. And quorum sensing is a phenomena by which relatively innocuous organism can acquire increased virulence and become pathogenic. And what is happening here is that the bacterial enzymes break down tears and release free fatty acids, which are highly irritating to the eye, which result in disruption of tear film integrity. So these bacteria are basically destroying the tear film, and this destruction of the tear film is causing tear film instability by reducing or disrupting tear film integrity. So in effect, blepharitis is causing a dry eye, and as you will see, most of the symptoms of blepharitis are the symptoms of dry eye. The seborrheic type, again, the exact cause is unknown. The risk factors are pre-existing dry eyes. Tears have many protective components in them, and loss of those protective components can lead to inflammation of the lid margin. Demodex infestation. Demodex are mites. I'll show you a picture. And it is theorized that the waste material of the mites, their poo, cause blockage of the hair follicles and the glands of the hair follicles, and they incite an inflammatory reaction, and that inflammatory reaction disrupts the tear film stability, or results in tear film instability. Skin disorders, something like acne, seborrheic dermatitis, psoriasis, and atopy are all something that are associated with the blepharitis. Excessive use of electronic display devices. Again, this is something that's coming up really, really fast, because everybody is stuck to a cell phone or a laptop. And what you do is, and if you ever noticed, when you are using one of these devices, you don't blink as much. And if you don't blink as much, your tear film is not replaced as frequently, leading to tear film instability and dry eyes. And excessive use of eye makeup causes blockage of tear ducts, causes dry eyes. So excessive use of eye makeup by either gender causes anterior blepharitis because it blocks tear ducts, which causes tear film instability. So all of these things that we have talked about, either in the Staphylococcal or the seborrheic variety in one way or another, are causing tear film instability and dry eyes. And even seborrheic dermatitis is something that might even be caused by a pre-existing dry eye, and it would thus worsen that dry eye. So this is Demodex infestation. These are eggs. This is the actual mite. This is on lashes of a patient. And these are the symptoms. And these symptoms, burning, watering, redness, irritation, blurred vision, and photophobia, are all because of tear film instability, leading to lid margin inflammation. Tear film instability because of lid margin inflammation. And because you have the hair follicle or the cilia or the lash associated with the interior lid margin, you would have falling lashes and lid swelling as well. And when you talk about the signs, you would have erythematous and edematous lid margins, swollen and red lid margins. You will have hard scales at the base of lashes in the Staphylococcal variety, and that is basically responsible for the falling lashes, and also they can misdirect lashes as well. You can have tear film instability, which is basically the main mechanism by which the symptoms of this disease are produced. If you go back and remember, for Staphylococcal variety, it is that bacterial enzymes that break down the tear film or the components of the tear film, releasing highly irritable free fatty acids that disrupt tear film. And for the seborrheic variety, there are various mechanisms by which the tear film is disrupted. For seborrheic blepharitis, you again would have erythematous and edematous lid margins, which is less as compared to the Staphylococcal variety. The scales now are oily and greasy, and they sort of crust the lashes rather than being at the base of lashes. You can have misdirected or falling lashes, and again, you would have tear film instability. What is this tear film breakup time? We'll just talk about it and actually see what it is. So these picture A represents the seborrheic type. You can see crusting of the lashes. This is the Staphylococcal type. You have hard scales at base of lashes, and you can see many of the lashes are missing as well. This is basically tear film breakup time. Remember, we keep talking about tear film instability. Tear film instability is when the tear film doesn't stick to the eye for the required time. And it's usually when the tear film is not able to stick to the eye for at least 10 seconds, that tear film is defined as an unstable tear film. And we check it by using a dye called sodium fluorescent. And this is the same dye that you use to do fundus fluorescent in geography and also stain corneal erosions and ulcers. This dye stains tear film. And the benefit is you can actually see the dye. You can't see the tear film because it's all transparent. So once you have stained the tear film, what you are doing is you are looking for a break in this tear film. And wherever the tear film will break, you won't see the dye. You will just see a clear zone. And if you start seeing clear zones less than 10 seconds after the tear film has formed on the cornea, that is defined as an unstable tear film. So what you do is you put the dye into the eye and you tell the patient to blink a couple of times and then to hold the eye open and not blink. So we'll just see how this is done. Nice music with this. And these are the clearing zones I'm talking about. So just notice the amount of time. 1, 2, 3, 4, 5. 1, 2, 3, 4, 5. So it's within about 5 seconds you start getting a break in the tear film, which is represented by clear areas where there is no dye. So this patient would have an instability of the tear film. So what do we do? Well, as we said before, this is a condition that's not going to go away. It will have its remissions and exacerbations. It will come and it will go. So this is going to remain with the patient for quite a bit of time. So we need to tell the patient that this disease is very hard to cure, but it can be managed. And the reason that this is very hard to cure is most of the time it has to do something with the environment. If it is staphylococcal infection, you can give treatment, but as soon as you withdraw treatment, sometimes what happens is that the disease comes back and you can't give antibiotics forever. So you tell the patient, we'll try and manage your symptoms, but do understand that this disease usually is not completely curative. It can be controlled. And the most important thing is to keep your eyes clean, because simply cleaning your eyes would help in reducing those scales, number one, and it would also help to reduce the bacterial load, which would in turn improve your symptoms. And there are various things by which you maintain your lid hygiene. And this is something that the patient needs to do indefinitely, because remember, this disease comes and goes, comes and goes. It's very difficult to cure completely. It's very difficult to cure because these things that causes are very difficult to get rid of. Warm compresses loosen scales and also warms your meibomium glands, which would increase oil output, and this oil would retard tear film evaporation, because the oily layer of the tear film retards tear film evaporation, would increase its stability. Lid massage would express mebum or oil from the mebomium gland, which would again improve tear film stability. Baby shampoo and lid cleansers would remove the scale and debris, and would also remove all those free fatty acids that are accumulating in the eye that is actually causing that irritation. And reduction in use of makeups by either gender. Lubrication, preservative-free lubricants, ideally preservative-free. We get preservative-free lubricants in Pakistan, but we get them in a bottle. So I don't know how long they actually would be efficacious. But if you can get minims, which are one-time use drops, so you break the little bottle or a minim, you put the drop in your eyes and you throw it away. And you can use them for as long as you want, which would be indefinitely. But you sort of reduce the amount of dosing, and as preservative-free tear films are very safe, you can tell the patient use them as frequently as you want. Topical antibiotics for Staphylococcal blepharitis, it's bacitracin, it's the Polyfax eye ointment, 3 times a day between 2 to 8 weeks, or usually until resolution. But as I said, once the inflammation resolves and you stop the antibiotic and you're not doing anything else, you're not doing lid hygiene or lubrication, the thing does tend to come back, because staph epidermidis is something that lives on your skin. It'll come back, and by quorum sensing, it'll become strong again. Steroid and antibiotic ointments have also been prescribed to reduce the inflammation. Remember, this is an inflammatory condition, but there is no long-term proven safety of steroids. Remember, steroids can cause cataract and glaucoma. So if it has to be prescribed, it has to be for a limited time, and it's usually an ointment that is given because ointments work better. Finally, topical cyclosporin and tacrolimus, 0.03%, cyclosporin in the form of drops, tacrolimus in the form of ointment at nighttime is pretty effective in these conditions. Again, it can be given for varying amount of duration, and it's usually better to give this than to give a steroid ointment. So this is how lid hygiene is done. This is a video from Singapore. And it's really important. It might seem funny to you, hey, what am I watching? But this is really important. You need to be able to tell this to your patients. And again, as I said, this is a very common eye condition. And as a family physician or a general practitioner, you're likely to get patients with blepharitis, so you should know what to do about them. It's not that difficult explaining this to a patient. You can even show him this video or pass on this video through WhatsApp, the advantage of technology. And although you can't get this prepared lid scrub in Pakistan, you can simply use baby shampoo and water to create something very similar. Baby shampoo simply because baby shampoo does not irritate the eye. And obviously we do both eyes, not just one eye. And obviously when we do it, we are going to do both the upper and the lower eyelid. We do both eyes because these are bilateral conditions. Yes, it might seem mundane, but it really helps. But again, as I'm saying, we don't get these prepared scrubs, so you just mix baby shampoo, Johnson's baby shampoo, L'Oreal baby shampoo, any baby shampoo in water and make your own scrub. A couple of drops and a little bit of water is usually sufficient. And you tell your patients to wash his or her hands with soap and water like this patient did. You don't want the gunk from your hands going into your eye. And you don't rub dry, you just dab dry. Rubbing would worsen inflammation. This is how lid massage is done properly. And this helps express the mebomium gland secretion, mebum, to express out of the glands, which improve tear film stability, because this is the oily layer which retards evaporation. And with time, the patient can learn to do it himself, herself. You really don't need to use a Q-tip. You can use your fingers as well. So if you don't treat it properly, or if this sort of continues or is incompletely treated, it can lead to a formation of a clasion or a hordelum. A clasion is a chronic sterile lipogranulomatous inflammation of the meibomium gland or gland of Zeiss or gland of Zeiss, which are sebaceous gland. These are the ones that are associated with cilia or the hair follicle. It can also cause a hordelum, which is an acute purulent inflammation, an infectious inflammation of one or more of the eyelid margin structures. We'll see what they are when we talk about these two lesions in the next subheading of lid margin anomalies, which is lid swelling. We will now talk about posterior and mixed blepharitis. Mixed blepharitis is just going to be anterior and posterior together. So we'll talk about posterior blepharitis, and then mixed would be just the two of them together. So posterior blepharitis is bilateral chronic inflammation of the posterior part of the lid margin. It is again of two types. The first one is called Mebomianitis, and this happens because of quorum sensing, exactly the same as the Staphylococcal variety of anterior blepharitis. Here, the bacterial enzymes are breaking down mebum. Mebum is the secretion of the mebomium glands, so that their nature changes from oily to semi-solid. And since this secretion is the one that prevents or retards evaporation of tear film, once this becomes semi-solid, it won't be able to spread on the tear film, causing tear film disruption. The other one is called mebomium gland dysfunction, and this is more of an age-associated change in secretion of mebum from oily to a semi-solid form. So mebomianitis is again because of quorum sensing. The exact cause of quorum sensing is unknown. It's thought to be occurring because of either changes that occur at puberty, diet, if you have a lot of fat in your diet, poor lid hygiene, excessive use of eye makeup by either gender, and medication, especially medication that's taken for acne, which is thought to increase bacterial proliferation in the lid margin. Meibomium gland dysfunction is something that's associated with age, and it is a chronic diffuse abnormality of meibomium glands characterized by obstruction and qualitative or quantitative changes in their secretion, i.e. their secretion becomes semi-solid from an oily form, as we just talked about in the previous slide. And the symptoms are again going to be very similar to the symptoms that we saw in anterior blepharitis, again either because of meibomianitis or meibomium gland dysfunction, the tear film is getting unstable. The tear film is getting unstable now because the oily part of the tear film is not covering the tear film, because its nature has changed from oily to semi-solid, so it can't spread on the tear film. The tear film evaporates very quickly, leading to its disruption, which causes symptoms of tear film instability, i.e. symptoms of dry eye. And these symptoms are going to be worse in the morning because tear film production is worse at night. It reduces at night, so these symptoms are really bad in the morning. And the symptoms are similar for meibomium gland dysfunction as well as mebomianitis, because essentially both of them are changing the nature of secretion of mebum or from meibomium glands. And again, the disease is going to come and go, come and go, come and go. You really can't sort of get rid of it, and even naturally it would get worse, it would get better, especially depending upon the treatment that the patient is taking or the protective steps that the patient is taking for himself or herself. And again, they will be associated with varying amounts of lid swelling. When we talked about the signs between the two are also very similar, because essentially in both of these conditions, it's just the nature of the secretion of meibomium glands, i.e. mebum that's being changed. So you see capped meibomium glands with yellow cheesy secretions, which is the semi-solid mebum sticking to the openings of the meibomium gland. Poor tear film stability. The tear film evaporates very quickly, so your tear film breakup time is again reduced, and you see a little bit of inflammation around opening of the meibomium glands. So this is what those capped meibomium glands look like, and this is because of a change in nature of their secretion from oily to a semi-solid form. This is mixed blepharitis, posterior blepharitis, anterior blepharitis. You can see hard scale at the base of lashes, so this is probably staphylococcal blepharitis together with posterior blepharitis, and you can see capped meibomium glands because this mebum is now semi-solid rather than oily, so it's stuck to the opening of the glands rather than spreading onto the tear film. This is again mixed blepharitis. You can see again hard scale at the base of lashes together with these capped meibomium glands. And this picture is the same picture that we saw when we were talking about anterior blepharitis. Those amongst you who saw these gaps, good for you. So what are the management? And since posterior and mixed blepharitis and even anterior blepharitis are very similar in the sense that they are all affecting lid margin and they're all affecting in some way tear film stability, so most of their management is similar. Posterior blepharitis and mixed blepharitis, there's only one step that's different, and I'll tell you as we get to it in the management of posterior and mixed blepharitis as compared to the management of posterior blepharitis alone. So communicating with the patient, again, tell the patient that this disease is going to come and go. It's not something that we can get rid of, but we can control by using certain things that we'll just talk about in a bit. And they're very similar to what they were in anterior blepharitis. Lid hygiene, again, is the best thing that you can do, and you need to do it for basically for an indefinite period of time. Again, warm compresses, lid massage, baby shampoo, and again, reduction in use of eye makeup. Very similar to what we were talking about when we were doing anterior blepharitis. Lubrication, again, similar. The reason is same as before. Oral antibiotics here are something that you do for posterior blepharitis and mixed blepharitis. And the reason that we are taking these on is for their anti-inflammatory properties, because they sort of reduce the lipid enzymes, or they reduce the activity of lipid enzymes of the bacteria. So they have anti-lipase actions which improve tear film stability simply because they don't allow those bacterial enzymes to break down the tear film. And doxycycline 100 milligram for 2 weeks and once a day for 6 to 8 weeks tend to provide good relief for you. For mixed blepharitis, we'll add topical antibiotic or an antibiotic steroid ointment. Simply, we are using these ointments to additionally cover the anterior blepharitis. But again, as I said, when you are prescribing an antibiotic steroid ointment, its efficacy is unproven and the side effects of steroid must always be kept in mind. Topical cyclosporin drops or tacrolimus ointment is something that also works well for the same, and it's used in the same way as it's used for anterior blepharitis as an alternate to a steroid ointment. And this is usually given at nighttime, and it's usually quite efficacious, and you avoid the side effects of steroids. So what are the complications of posterior and mixed blepharitis? They're the same as for anterior blepharitis, which is occlusion and hordelum. We will now talk about the last half of our discussion, which is lid swellings, and we'll start off by talking about benign lid swellings, and then we'll move on to malignant lid swellings. We are getting to the end. As I said, it's easy as swimming as a fish. Yeah, because it comes naturally to fish, Humans is another thing, but fish, hey, without swimming, fish would not be fish. So before we go on and talk about those lid swellings, let's just have a look at some structures. So this is the lid crease, this is the anterior surface of the lid, and these are the eyelashes. The lid crease is formed by the insertion of the levator palpably superioris, the elevator of the upper lid, onto the skin of the upper lid. This is a cross section of the lid, and what I'm showing you are the various glands and this eyelash that are going to be producing these benign swellings. So we have gland of Zeiss or gland of Zeiss, which is a sebaceous gland associated with the eyelash. This is basically the oil producing gland of the eyelash. Gland of Moll are apocrine sweat glands, and they are located at the lid margin, the interior lid margin. The Mebomium gland we have already talked about is the gland that's within the tarsal plate, and it is a modified sebaceous gland, and it produces Meibomium, which is the oily part of the tear film. Then you have the tarsal plate, which is basically a thickened part of which is a thickened fibrous tissue which gives the lid its shape. The posterior half of the lid is covered, the posterior surface of the lid is covered by conjunctiva, which is called the palpable conjunctiva. The orbicularis oculi is a muscle that closes the eye, and the interior part of the lid is covered by skin. So the interior lid margin has your cilia, gland of Zeiss and Moll together and it's covered by skin. The posterior lid margin has orifices or openings of Mebomium glands that is covered by conjunctiva. So the benign lid swellings that we'll talk about are either chalazion and hordelum, and the malignant lid swellings that we'll talk about are basal cell carcinoma and squamous cell carcinoma. So we'll talk about benign lid swellings first, and benign lid swellings, We'll start off by talking about benign lid swellings, and benign lid swellings are either infectious, purulent, or non-infectious, i.e. sterile inflammation of the eyelid and or its margin. It's of two types, a chalazion, which is a chronic sterile implying non-infectious, lipogranulomatous inflammation of the meibomium gland or the gland of Zeiss, and both of these are some form of sebaceous glands. A hodulum, on the other hand, is an acute purulent inflammation, i.e. it's because of an infection of any one or more of these structures: hair follicle, gland of Zeiss, gland of Moll, or a meibomium gland. If it's if it's the hair follicle, gland of Zeiss or Zeiss, or a gland of Moll, it's called an external hodulum. If it's the meibomium gland that's involved, it's then called an internal hodulum. We'll start off our discussion by talking about the chalazion. And a chalazion is a focal, chronic, non-infectious, i.e. sterile, lipogranulomatous inflammation of meibomium gland or gland of Zeiss. It usually starts off as a small, swollen, red area on your eyelid that usually turns into a painless nodule over a period of days. And its etiology is again because of retained secretion within these glands. It incites an inflammatory reaction leading to this lesion, a chalazion. And the risk factors are dry eyes, blepharitis, and smoking. We've already talked about anterior and posterior blepharitis and mixed blepharitis as possible reasons for formation of a chalazion. The presentation of a chalazion usually depends upon when does the patient present. If a patient is presenting within hours to a couple of days, it's usually a small tender. Tender would mean that when you touch it, it's painful, otherwise it's not. So it's a small tender nodule located on the lid margin, if it's gland of Zeiss that's involved, or on the lid surface if it's the meibomium gland that's involved. And at times it's very difficult to differentiate it from a hodulum, especially if it's a gland of Zeiss that is involved. A patient who presents a little later, maybe days to weeks, would have a painless nodule. Remember, this usually starts off as a small area of inflammation that turns into a painless nodule over days. So if a patient is presenting early, he's going to present, or she is going to present with a small tender appropriate. It's not painful, it's mostly tender. You get pain when you touch it. A small tender swelling, which is located either at the lid margin or on the lid surface in an acute stage, which is presenting within days to hours. If the patient presents later, probably close to a week or more, he or she will present with a slow growing nodule, which is painless on the lid margin or on the lid surface. And at times, because the patient usually does not notice the acute event, the lesions insidiously appears as a painless nodule. The patient would wake up one day and say, there's something going on here. Or someone else would tell them there is something growing on your lid. And the good part about chalazion is that sometimes they would just drain themselves. Remember, this is because of retained secretion. So once they start swelling up, the pressure within the gland, or glands, depending upon gland of Zeiss or meibomium or both together, builds up. The pressure within these glands build up so much that they sort of spontaneously drain. It is also possible for a chalazion to become infected, and then it's called an internal hodulum. We'll talk about internal hodulum when we talk about hodiolas. We'll do that next. It is also possible to have multiple chalazia in the same lid. And it's also possible to have bilateral chalasia, especially if you have any of the risk factors. And you can have internal and external hodulum together with chalazion as well. So you can have all possibilities of these benign lid swellings going on at the same time, with blepharitis as well, because blepharitis is a risk factor. So you see how common these conditions are. Blepharitis is the most common thing you see, and these are complications of blepharitis. The chalazion, styes, blepharitis is something that you see very frequently in an ophthalmologist clinic, and also in a general practitioner or a family physician clinic when we talk about specific eye presentations. So these are two chalazion, lower lid, upper lid, smaller, larger. What do we do? Most of the time you don't need to do anything, they spontaneously go away. You can control or treat the risk factors, blepharitis being the most important, lid hygiene, and everything else that we talked about when we were talking about blepharitis. Warm compresses work very well because remember they are retained secretions. If you apply warm compresses, it would help drain the gland. And you need to do it properly and very religiously in order for these to work. And the best way to do it is to, and this goes for blepharitis as well, take a small towel, warm it up with medium iron or a little bit of lukewarm water, touch it to the lobe of your ear so that it doesn't burn. put over the lesion and just gently compress for about 5 to 10 seconds, let go, repeat the process maybe 10 to 15 times in one sitting, 5 to 6 times per day. Even better are one of those beads that you get. I have some in this packet. This is not the best example, but I will show you. You have this bead-like things. I use it to protect my wrist. You can put them in a microwave, heat them up, and you can put them over your eyes. And they usually come in a protective covering like this. So you don't just put this over your eyes and burn your eyes. You warm this up, you put it in this, and then you put it over your eyes. And it provides a very nice feeling. It also works well for headaches, I've been told. But this gel-like thing, it's relatively easy to get here as well. I've seen some online, and they're not really expensive, and they work for other things as well, in addition to just doing warm compresses to your eyes. But I don't use it for warm compresses. I use it to protect my wrist against repetitive strain injuries, RSI, carpal tunnel syndrome, because I have to make these videos for you. I have to sit 7 hours for one video. I have to toil, I have to work, so that your training and your teaching does not suffer. Anyways, if warm compresses or it does not spontaneously go away, or if the lesion is older or it's a firm clasion, i.e. There's a lot of granuloma formation. Remember, this is a granulomatous inflammation. And obviously, if the other treatment methods have failed, you can do incision and curettage. We'll see what incision and curettage is in a bit. And if it's a recurrent clasion happening in the same place over and over again, especially rather quickly, especially in old age Caucasians with a history of sun exposure, think of malignant tumors masquerading as a clasion. They can do that. We'll see how that happens when we talk about malignant lid lesions, which is going to be the last topic today. So this is how an incision and curettage is done. We give a little bit of local anesthetic injection. We apply something called a clasion clamp in the area of the clasion, and we evert the lid, and we give a vertical incision into the mebomium gland where the swelling is, and we basically curate the secretions out. This cheesy necrotic material is all the secretions that were collected inside, and you really have to work at it because there might be some granulomas inside that have to be dissected out. And you can see a lot of cheesy material coming out. That was all the retained secretions. You have to really clean it up because you don't want anything remaining behind, because that would lead a little firm nodule and you'll have to come back and do it again. So might as well do it properly the first time. And this is something that a family physician or what do they call? A general practitioner can do if they have a little bit of eye exposure. Maybe eye house job with 6 years to 1 year experience in ophthalmology. This is not a very difficult surgery to do. You don't need a microscope. You just need to make sure that you're looking at a clasion and you know what to do to a clasion. Now we are moving on to a hordelum. Hordelum are purulent or infectious inflammation of the lid margin, and we've already talked about the structures that can be involved. It could be the hair follicle of the eyelash, gland of Zeiss, gland of Moll, or the mebomium gland, or a combination thereof. An internal hordelum is an obstruction and infection of mebomium gland. An external hordelum is also called a stye, is an infection of one or more of eyelash, hair follicle, gland of Zeiss, or gland of Moll. The etiology is staphylococcal infection of any one of these structures involved. And the risk factors are dry eyes, again blepharitis, anterior posterior mixed together, or Demodex infestation. Demodex infestation is also a risk factor for blepharitis, so you sort of may want to just include it there as well. If it's anterior and posterior, it obviously implies that it's mixed. And we've already talked about anterior and posterior blepharitis and how both clasion and hordelum are complications of the disease. So how does an internal hordelum present? Internal hordelum present with pain, swelling, and redness of the eyelid. And it is going to be, those are the symptoms. A sign is going to be a localized purulent edematous and erythematous inflammation on the posterior surface of the tarsal plate. Remember, this is a mebomium gland that's getting infected. And the mebomium gland is located in the tarsal plate, which is closer to the palpable conjunctiva. So you see it better when you evert the lid. We'll see some examples in a bit. And obviously, because the lid has a lot of soft tissue around it, you will see a little bit of cellulitis together with both internal and external hordelum. An external hordelum is pain and swelling and redness of the eyelid. So the patient presentation between an internal and external hordelum would be very similar. However, because the external hordelum are structures, external hordelum is a swelling of structures or infection of structures that are located in the interior half of the lid margin. They are seen without doing any everting or anything else. So they are localized, purulent, edematous, erythematous inflammation at lid margin, and usually associated with eyelash, because all of these glands and the eyelash itself are very closely associated with one another. And again, you will have various levels of cellulitis of the surrounding tissue, because there's a lot of loose tissue in the skin, and the infection and the inflammation can easily spread. And it is possible to see them together with the chalazion. And because blepharitis is a factor that can cause these, you can see blepharitis, chalazion, and hordelum, all of these things in one patient. Maybe in one eye or in both eyes, or maybe in both eyes and both upper lid and lower lid. I've actually seen that. So this is what an internal hordelum would look like. You have to evert it because this is the meibomium glands that's infected. So it's best seen when you evert it. And you can see a little bit of cellulitis surrounding the mebomium gland, and it's all full of purulent material, which can be seen by these yellow swellings, which is visible through the conjunctiva. Remember, the tarsal plate or the posterior half of the lid margin is covered by the palpable conjunctiva. So you're seeing this through the palpable conjunctiva. This lesion is actually located within the meibomium glands, which are located within the tarsal plate. So this is as you are seeing it through the palpable conjunctiva. This is an external hordelum or a sty. You can see it right here. You can even see a pus spot. And this is either because of gland of Zeiss, the eyelash follicle itself, or a gland of Moll that causes this lesion. This is a sty that's spontaneously ruptured. This is again an external hordelum or a sty. You can again see a pus spot here. You can also see a little bit of cellulitis, this redness associated with this sty. You can see a lot of cellulitis or redness associated here as well. The white arrows are basically showing you the significant amounts of cellulitis associated with external hordelum or sty in these patients. This is a patient who has a chalazion and a sty together, and no marks for guessing which is pretty clear, and it's also labeled. So all of these glands can be involved in this patient in the process of infection. So the management of a hordelum would depend upon how the patient is presenting. Sometimes they just spontaneously go away on their own between 5 and 7 days because the inflammatory process is pretty limited. Warm compresses are something that will hasten this process. The first thing to obviously do is to look for factors that would preclude a patient to developing a hordelum, which would be a blepharitis or demodex infestation. So lid hygiene, again, together with all the other factors that we've already talked about when we talked about blepharitis, need to be taken care of in order to control the risk factor that produces a hordelum. Topical antibiotic ointments are prescribed as an initial presentations, just to hasten the resolution. So if the patient is presenting to you and it's not been 5 to 7 days, and you know that this might spontaneously resolve on its own, you can still prescribe an antibiotic ointment, a topical antibiotic ointment, so that it resolves quicker. It sort of looks ugly, and it might, sort of distract a person from doing what he does. So you can give a topical antibiotic for this. It is also given if the lesion does not resolve within 5 to 7 days. And the ointment that you use is Polyfax eye ointment 3 times a day till resolution. Oral antibiotics and non-steroidals are indicated for hordelums with significant cellulitis, like the pictures that we saw before. I'll show you these pictures again, these ones. So here in these patients, you might want to give a beta-lactam antibiotics for 5 times a day together with NSAIDs. The dose would be according to the strength of the drug that you're giving. If it's a 1 gram preparation, it's BD. If it's anything like 625, it's 3 times a day. NSAIDs is your choice, whatever the patient prefers and would work best. Just remember that Panadol or acetaminophen is not a non-steroidal anti-inflammatory drug. It's really important to remember that. Don't confuse it with an confuse it as an anti-inflammatory drug. The complications that you might see in a hordelum are preseptal cellulitis and an orbital cellulitis. A preseptal cellulitis develops because, remember, hordelums are associated with some level of cellulitis anyways. So if you have a patient who has a hordelum, either internal or external, which has significant levels of cellulitis, and you inappropriately treat it, i.e. either give no treatment or a topical antibiotic when a systemic antibiotic was indicated, the patient might get a preceptal cellulitis. There are certain factors that predispose a patient to developing a preceptal cellulitis. It includes virulence of the organism, the level of stress the patient has, the age of the patient. Extremes of ages are obviously more predisposed. The immune status of a patient, whether the patient is pregnant or not. So all these factors may predispose a patient to developing a preceptal cellulitis. It is possible for a preceptal cellulitis to become an orbital cellulitis, which can be sight and life-threatening. So it's really important to deal with those, and we'll talk about those when we've already talked about those, or we'll talk about those at the end of this theme. So you'll get to know more about these types of cellulitis then. Finally, we are moving on to malignant lip tumors, which is the last thing that we'll discuss. Our fish is ready to swim. We'll talk about basal cell carcinoma and squamous cell carcinoma as two malignant lip tumors. We'll talk about basal cell carcinoma first, and this is a malignant epidermal tumor of the eyelid skin. It is the most common eyelid malignancy. 90% of all eyelid malignancies are basal cell carcinomas. It is mostly unilateral, and it equally affects males and females for eyelid tumors. For other tumors on the body, it's usually males more than other basal cell carcinoma on the body, except the eye. It's usually males that are affected more than females. The etiology is UV associated damage to the skin, and the risk factors are increasing age and fair skin. Increasing age would mean, 6th decade, 5th decade, or later in life. You can get it earlier as well. If you have a lot of sun exposure, you would like to sunbathe and you would like to sunbathe, and you don't apply appropriate sun protection. The presentation is usually a unilateral mass that's growing on the lid, and sometimes the patient is unaware of it and it's usually pointed out by someone else. It does spread a lot locally, but it does not metastasize. So it causes a lot of morbidity, but no mortality. And again, as we have said, a recurrent clasion might be masquerading a basal cell carcinoma. There are three types of presentations: a nodular presentation, which looks something like a clasion, a nodular ulcerative type in which the nodule has formed and ulcerated and has these very rough edges, which is called a rodent ulcer. And there is a sclerosing or a morphia form type, which has this diffuse thickening of the lid, which is the least common type that you see. So this is a nodular type. It has these pearly or opaque outer, pearly or sort of, pearly type of margins. They're shiny margins, but it does or tend to look like a clasion at times. So this is an ulcerative form in which the margins appear very rough. They're sort of eaten into margins. It's called a rodent ulcer type. And there's a sclerosing type, which is causing the thickness of the entire lid. The most important thing is to prevent it. And a primary prevention is simply by avoiding sun exposure or using appropriate sunblocks. If a patient does get it, you need to do something called frozen section with biopsy. You do a frozen section because when the patient is on the table and you have cut away the lesion, you need to ensure that the margins of your excised tissue does not have any abnormal cells. And that is all frozen section tells you. It does not tell you the type of tumor. It does not tell you anything else. All it does is tell you what type of cells are present in the margin, whether they are normal or abnormal. And you need to make sure that the cut edge of your sample, the excised edges of your sample, are all normal cells. Because if they're abnormal cells, that would mean there are some tumor cells left in the tissue on the lid. Because if there are tumor cells or abnormal cells in the margin, there are obviously abnormal cells left where the tissue was excised from, so you need to cut a little bit more. And the advantage of frozen section is it provides immediate results. So when the patient is on the table, you can do a frozen section, wait for the result, and if the result is all normal cells in the cut end, that's it. You don't need to do anything else. But if the frozen section report comes back and the patient is still on the table because this process is rather quick, and the report says no, there are abnormal cells in the margin, and maybe the medial margin or the lateral margin or the superior margin or the posterior or the anterior or the posterior margin, then you need to cut more from that side. And you need to keep repeating it until your frozen section says all margins clear. And then you need to repair the defect. Sometimes you might use grafts or flaps. So you need an oculoplastic surgeon for this. I'm going to show you a little video of how a frozen section is done. And the first step is basically gross examination of the tissue, just to verify that this is a sample that was sent to them. And then what you do is you cut the sample, and then what you do is you identify, you mark it with ink to identify the margin. Each margin would have a different ink color, so you know this is the anterior margin, this is the posterior margin. Since this only has one margin, it is covered by one colored ink. And then what is done is you take very thin slices or tissues, and you will put them onto something called a cryostat. A cryostat is a microkeratome that can freeze a tissue at the same time. So this tissue is then taken over into something called a cryostat, this machine right here, and it is then put over a paraffin block, and then you spray it with a spray that basically is going to freeze it also. So this is right now a process of freezing it, and this spray was just helping or assisting in the freezing process. That's why it's called a frozen section. And then it is cut into this keratome, and this keratome is within this machine, and it is kept in this machine so that it's cold enough so that the tissue remains frozen. Freezing is important because it fixes cells in space. Again, some spray to, you know, keep the freezing process there, or to sort of ensure that the tissue is frozen. And you cut thin sections. That's what a microkeratome does. And then this is transferred onto a glass slide, which is then appropriately stained. It's just going to be stained in a bit. The staining is coming up. Trust me, the staining is coming up. Here we go. This nice lady is going to take it and put it into stain. These are hematoxylin and eosin stains that they are going into. The sample is going into. And this is all the time that the patient is actually on the table. So the patient hasn't gone anywhere. And that's really important, because if the sample or the report says there are abnormal cells in the edge, you need to go back. So if I pause it here, this is the cut edge. It is the ink or the dye that we use to stain. It is showing you that this is the cut edge, and this is where the pathologist is looking to see the abnormal cells. Now, if the pathologist says there are abnormal cells here, and he's not going to identify these cells right now, all he knows that this is coming from the lid tissue, and he's going to look here, and he knows that the lid is covered by a stratified squamous epithelium of the keratinizing type. So he says, yeah, these are all normal cells. So if in all the cut sections which are stained by the dye, the cut edges, if all of them have normal cells, it's fine. He will say cut edges have normal cells. But if any of these cut edges have abnormal cells, he will tell you that this cut edge, which will obviously be stained by a particular color of a dye, this cut edge has abnormal cells. So the report would go back to the surgeon, and the patient is still on the operating table, so he can take a little bit more, he can excise a little bit more tissue, send it back for frozen section again, because we need to ensure that the cut edges don't have any tumor cells, because the tumor cells can simply spread from there. The last thing that we do today is squamous cell carcinoma, and squamous cell carcinoma is a malignant epidermal tumor of the eyelid skin, much like basal cell carcinoma. The difference being this is lethal because it can metastasize. It's unilateral. It's the second most common eyelid malignancy, 5% of all eyelid tumors, and it's most commonly found on the lower lid. The etiology and risk factors are similar to those of basal cell carcinoma. The presentation is also very similar to basal cell carcinoma, with the difference that this is a more rapidly growing tumor. It has metastatic potential. And again, just like with basal cell carcinoma, a recurrent clasion may be masquerading a squamous cell carcinoma. There are again three types: a nodular type, which is a painless opaque nodule; a nodulo-ulcerative type with nodule and a central ulcer; or a plaque-like form in which you have a sort of a diffuse thickening of your eyelid skin. This is a nodular type, this is an ulcerative type, this is a plaque-like type. Again, the management is very similar to basal cell carcinoma. Primary prevention in the form of avoiding sun exposure, use of sunblocks, excision of tumor with frozen section, excising till the margins are clear, repair of the lid if necessary, if the defect is too large and may require grafts or flaps, and you require an ocular plastic surgeon to do it. You need to scan for metastases here, and that's really important. You need to scan for metastases because this disease can metastasize and can potentially kill. So once the tumor has been excised, you send the patient to an oncologist for a proper tumor scan or evaluation of the tumor, so which might include abdominal scan, a chest x-ray, and even an oncology referral. That's my cat going crazy. So that's it. This is the end. Our fish has finally learned how to swim. If you have any questions, you know where to ask, and I'll see you in your next discussion.